It's a pleasure to be here. Wonderful introduction. My name is Dr. Pole and I work at the Baton Rouge Cardiology Center. So I'm going to tell you all about something that's near and dear to my heart. This is what I do every day, all the time, in and out. This is the most common thing that I treat: atrial fibrillation, heart rhythms, this type of problem, condition. I'd like to brief kind of overview about this. What is AFib? What types there are? A little bit of understanding of how AFib sort of affects your heart. And then, of course, what puts you at risk for AFib? Why does it even happen? Big question about atrial fibrillation and the relationship with stroke. And then I'd like to introduce some topics about how to treat AFib, or what we try and do in the cardiology community to get this under control. Oh, that's too many clicks. So first and foremost, atrial fibrillation is a disorganized rhythm of the upper chamber of your heart. Now, the lower chamber of your heart is where the muscle, the really important, let's say, muscle pumps blood to the rest of your body. When the bottom chamber contracts, you feel a pulse, you get blood flow through your body. But the bottom chamber is a workhorse, and it follows the commands of the upper chamber of the heart. The upper chamber of the heart needs to stay in rhythm. If it goes out of rhythm, the bottom chamber doesn't know what to do, and you get an irregular heartbeat, and you get a less efficient blood flow through circulation. Imagine a drummer walking down the street, or a marching band, versus my 3-year-old with a spoon in the kitchen and the pots and pans just making nonsense, all right? It's also extremely common. In 2019, we always have a little bit of delay about collecting data, but in 2019, there were more than 5 million new diagnoses of atrial fibrillation. That's not the number of people, that's the new people that year. So this is a very quickly accumulating problem. An important fundamental of atrial fibrillation is, how does it come around? Risk of it. And I want to point out right now that age is actually extremely important. It's very rare, although possible, to have AFib in your 30s, 40s, but every decade after that it doubles, and to the point where in your 60s and 70s it's about 1 in 4 adults. Weight loss is, I think I would say, the second most important contributing factor. When you have extra weight on your body, that's putting strain on your heart, and that eventually feeds back to the atrium and helps promote atrial fibrillation. We know with data that losing weight definitely helps control over time your atrial fibrillation, and you don't even need that much. Targeting about a 10% weight loss is very, very effective. Other major risk factors include let me talk about this on the left side, this non-modifiable. So we deal with things that are related to your lifestyle, as well as things that you just have that you're born with. As I said, age is a contributing factor. Darn you for continuing to age and putting yourself at risk for AFib. There's no problem with that. It's just how it is, unfortunately. Also, there's a genetic predisposition. It is not a one-to-one type thing, but if you have it in your family, there is a very high chance that it will come to you sooner on in life. And then other heart diseases play into the development of AFib. Also, one thing that's very important for me is that AFib causes more AFib. All right? And then you have lifestyle modification things like sleep apnea or difficulty sleeping, as I said, weight loss, alcohol consumption. I'll talk a little bit more about that. Lesser so, maybe caffeine. If you're just drinking a lot of caffeine, that is not really a major contributing factor, but we do know there are loose associations with many, many different pieces of the puzzle that help contribute to AFib. So it's very hard to say it's just one thing. Now I want to talk about alcohol. This is an important learning detail here. We know there's a stronger association with alcohol consumption, but the data is 0 versus 10 drinks per week. I don't know if one drink is going to cause a lot of problems for you. Some people do. They drink a glass of wine and that triggers atrial fibrillation. But the main point here is that excessive alcohol consumption is also associated with the development of atrial fibrillation. Now, unfortunately, there are a lot of populations that are undertreated. It turns out that African American patients tend to have more of the comorbidities that go with atrial fibrillation. And oftentimes they don't have as severe symptoms, and so their development of atrial fibrillation is maybe hidden for a bit longer than would be ideal, would be safe. Also, women, unfortunately, tend to not get into the treatment arm of atrial fibrillation as soon as basically men. Unfortunately, they don't often get connected to an electrophysiologist as quickly, and they may have more attempts at medical therapy, cardioversions, rather than perhaps a more long-term treatment strategy. The symptoms that women experience for atrial fibrillation are oftentimes different than what men experience. So right now, I want you to realize, summary of this point in the presentation, AFib is very, very common. The next question or next thought is, what does AFib do to you? The most common symptom, and this is a sort of something I run into, the most common symptom of AFib is actually just general fatigue. As I was mentioning, when your heart muscle doesn't contract as well as it should, you have less perhaps efficiency of blood moving through the body, and you have lower energy, and this is what you feel. That is a subtle finding. Most people are a subtle symptom. Most people don't say, oh, I feel great today and tomorrow I feel fatigued. It's a slow process, and you suddenly realize that you're not able to do what you were able to do a few weeks ago. And it turns out you were in atrial fibrillation. So there are symptoms of atrial fibrillation that some people don't appreciate immediately. With the general fatigue comes weakness. When you're exercising, you may feel short of breath sooner than you usually would. You might actually feel, let's say, more intense symptoms like feeling your heart fluttering or palpitating, or feeling anxious for an unknown reason, or maybe even sweating. So you may have a very obvious symptom. Many people do, but the most common symptom is actually subtle in development and affects your quality of life over time. And I want to sort of think about this. So on this lower section, when you develop atrial fibrillation, oftentimes you have a high heart rate, or the inefficiency of the heartbeat causes your overall exercise capacity to go down. And then you start to say, I talk to people all the time, and they say, oh no, I'm just getting older. I didn't sleep well for like 7 weeks in a row. I don't know if that's really what it is. So they develop coping strategies, and they start to slow down, and they have a sedentary lifestyle, and that sort of feeds back into developing more atrial fibrillation because their overall health gets worse. And it's a downward spiral. On the other side of the coin, and this is something that I'm going to talk about more in a sort of a slightly different path, atrial fibrillation also puts you at risk for cognitive problems. Some of this is in the form of, we think, small emboli or strokes, or just, let's say, poor nutrition to the brain. However, it's kind of multifactorial. But the point is, your cognitive function may decline over time as a direct result of atrial fibrillation. And this reduces your ability to function socially, and you start to lose interest in your hobbies. And hey, that plays back into getting into a sedentary lifestyle, and again, a downward spiral, worsening atrial fibrillation. So, regardless of if you have outright symptoms of atrial fibrillation, or if you know exactly when you go into atrial fibrillation, you are very likely to be at risk for stroke with atrial fibrillation. I need to talk about this. AFib increases your risk of stroke many times over, at least 5 times over, and with other comorbidities, quite a bit more. When we sort of look at all the strokes that happen, especially the ones that we don't have a good explanation for, at least a third of them are a result of atrial fibrillation. And it may take some months to sort that out. Unfortunately, AFib strokes are very bad. They are usually not simple things. If you have a stroke from atrial fibrillation, these are typically the more debilitating strokes. So this is I'm going to say, the most important component of atrial fibrillation. Just a brief sort of overview of what a stroke is, actually. When that blood flow in the upper chamber of the heart starts to become, doesn't move as well, it becomes inefficient, that blood can start to form little blood clots. And eventually, when that blood decides to move, either because there's a good contraction of the heart muscle or it just floats along its way, it can be moved to some other part of the body, including the brain. And when a small blood clot goes to a portion of the brain, that reduces the blood flow there, and that's a stroke. Signs of a stroke include sudden numbness or weakness, especially if it's on one side of the body and not on the other side of the body. Confusion, inability to speak or make sentences make sense. vision changes where there's a portion of your vision that goes out. Usually not the whole vision, but like pieces of your vision may go out. Trouble walking, discoordination, loss of balance, and a sudden severe headache that's terrible that you don't have another explanation for. So these are signs to say, hey, seek out medical emergency care. Overall, summary at this point, AFib is bad for you. So who treats AFib? How do you get into the clinical pathway for treatment here? I think most common contact is going to be with your primary care physician. When you start to notice something out of the ordinary, maybe it's fatigue. And it may simply be a matter of figuring out that your pulse is irregular. It doesn't sound like a marching band anymore. Or if you feel uncomfortable in other ways. They would likely refer you to a cardiologist, and through that decision path, you would eventually, hopefully, see an electrical cardiologist who specializes in this treatment. There are multiple types of AFib. It is a progressive disease process, and it occurs over months. When you have had AFib for months and months and years, likely more than 44 months, it becomes more difficult to treat. At home, you may find ways to find that you have atrial fibrillation with a blood pressure cuff that says your pulse is irregular, or you may have something like a Fitbit or a watch. Some watches can even record your rhythm strip, which is incredibly valuable because you can bring that data, it acts as an EKG, to your cardiologist. There's also other things that are a little cheaper than the watches, which is also a way to record rhythm strips. And this provides useful information for your clinician to act on. When you go see the cardiologist, they'll likely do an EKG, they'll likely look at your heart muscle with an echo, do a stress test, have some Holter monitors, work this up, see what your burden of AFib, when it comes on, when it goes away, look at how severe your atrial fibrillation is. And eventually you may get an electrical study from me to try and sort out more about this electrical pattern of your heart. But it is not straightforward. You may start a medication, atrial fibrillation will come back. You may get a cardioversion, atrial fibrillation will come back. Unfortunately, I can't tell you that there's a cure for AFib. This disease process will continually progress. But we do have ways to slow down the progression. And that's our goal currently with AFib management. So the clinical pearls, 4 things to take away from this. Number 1, puts you at risk for stroke. You must be on a blood thinner. Please don't neglect that. Number 2, when your heart rate is going very, very fast for a long period of time, it can make the heart muscle even weaker. So that needs to be treated in some days period of time. That's kind of the level of urgency. The rhythm is right now mostly a question of symptoms, quality of life. How do we, make you feel better over time? How do we slow down this whole process? And that it's not an emergency. We have weeks to treat that, weeks to months to treat that. And then I was mentioning the underlying causes that you may have some control over to help slow down this process. A cardioversion is a brief procedure done with a small amount of energy. Your cardiologist would talk to you about this. Don't be too concerned about this, but I want to point out something. It will suppress AFib for that moment, but the chances of AFib coming back are quite high. Even if you use medical therapy, the chances of controlling AFib in this manner are pretty darn low. It helps. It's definitely a method that we use, but there's no real permanent changes going on here. So we have medications. The blood thinners are the ones that help you control the stroke risk. As I've harped on the stroke concern, it's actually very well treated nowadays with certain new medications that have come out in the past 6 years or so that your risk of stroke is almost back to normal. And that's almost all you have to do, not to oversimplify it, but be aware of the stroke and then make sure you're on the appropriate therapy. When your heart rate is out of control, you may take a special medicine that is designed specifically to slow your heart rate down, to keep that under control. Even if you're out of rhythm, we want your heart rate to be at a good number, somewhere 60 to 100 sort of approximately. And then we have antiarrhythmic drugs. Unfortunately, these medications can become quickly overwhelming, and antiarrhythmic medications are not very effective. So it is a progressive disease, and it's important to seek treatment as soon as possible to improve quality of life over time and reduce progression of atrial fibrillation and reduce your risk for stroke. If medications aren't working, this is really where I step in. A catheter ablation is a specialized procedure where I pass small electrical wires into the heart study the electrical system, study the scar burden of the muscle of the heart, and modify it using energy to, let's say, heat it up, make it electrically inactive, and help the healthy part of your heart stay in control. All right? It's like a mad scientist. It's an excellent procedure, and we're getting more and more efficient at it and more safe at this procedure. And it's much more effective than medical therapy. It is, obviously I'm an electrical cardiologist, it is, in my opinion, equal to the first line of therapy for this rhythm, especially if you're early on in the disease process. Because, as I said, it's a downward spiral, and one of the things that causes more AFib is AFib. If we wait too long, the chance of ablation working well starts to go down. Okay, I said this. It's more effective, benefit, and improve quality of life. All right. That's actually a pretty good summary. If you came to see me in my clinic, this is what I would talk about as one of our first introductory conversations.